going to go ahead and get started in the next minute or so with our lunch symposium. So we have two lunch symposium. I would like to thank Axera as well as Penumbra for sponsoring the next two lunch symposium. So if I could ask, I would like to ask our next speakers. Dr. German-Wall is already here. Dr. Ramaya, when you get a chance, when you grab some food, you can come up to the table. Again, very casual lunch symposium. If you have any questions, please don't hesitate to ask those in between the talks. And I think we're going to have a couple of pre-recorded live cases as well. It's my pleasure to introduce our first speaker, Dr. German-Wall, who comes to us from Texas. An elite endovascular specialist, does a lot of vascular work, and it's our pleasure to have him this year at the Chicago Endovascular Conference.
Thank you. Thank you so much. Thank you for that really kind introduction. So today we're going to, and I also want to thank Axera for giving me the opportunity to speak here. So we're going to talk today about our experience with using the Axera self-sealing access in patients with peripheral arterial disease and amongst other vascular procedures where we're starting to use this technology as well. So when you start looking at the closure device market and trying to think about how you can continue to improve your practice and look at throughput, look at the various types of current closure systems that were available. And of course, manual compression is something that I think we all use, and even today we still use quite often within our own practice. Trying to think about implants, of course, we've had in the past sutures with the PerClose device, metallic clips, staples, StarClose, using plugs like the AngioSeal, ExoSeal, Minx. These are all things that we've used in the past, and they've worked. But when you're trying to think, and again, to talk about manual compression is very safe, effective. One of the great things about it is you're not leaving anything behind. And I think that's one of the most important things, particularly in the peripheral area, and a lot of us as endovascular specialists really don't want to leave anything behind since we're going to be coming in and out of the groin area. And with the closure implants, the advantages are obviously a shorter time to ambulation. These days in physician-owned labs and even in the hospital setting, the goal is to try to get the patients out of the hospital as quick as you can. And due to these financial burdens, we're trying to get folks ambulated quicker, achieve hemostasis as well a lot quicker. So when you're thinking about how would you come up with the ideal closure device? So obviously one of the things would be don't have any foreign material implanted, have a rapid time to hemostasis and a rapid time to ambulation, have minimal complications, patient comfort, easy to use, and ability to use it with just about any anatomy and disease, and ability to close, whether it's in various arterial beds or different locations, and then ease of re-accessing the artery right away, and then the cost. Those are really the big things. I think we've all seen these sorts of complications where we've had big retroperitoneal bleeds and large hematomas and major adverse events after you've done a great job with your long segment chronic total occlusion or something. So that's where we started using Axera in my own practice. I was at a master's course that I was doing with some folks about 3 or 4 years ago, and one of the surgeons there in Miami had told me about this device, and I never really heard about it. And over the last couple of years, I've adopted this into my practice. I can talk to you about my experiences with regards to that. But this is the Axera device. It's called by Arstasis, and this is the actual device. And it looks, when I first saw this, it's very similar to the actual PerClose device in its look. And one of the reasons is its inventor, Bruce Modisett, who's here in the crowd. So if you guys have questions or issues or concerns or thoughts on how it could be improved, you can certainly talk with Bruce later on, and I'm sure he would encourage speaking to you all. But it looks a lot like the PerClose device. That was one of the first things that I had thought when I saw it. So obviously, just being a cardiologist and being evidence-based, we want to know about how this works. And I'll show you some trial data in the recital trial. But one of the advantages of this sort of technique, where you have a self-sealing arteriotomy, is you really can decrease the amount of manual compression. And, at our institution, we're holding about 5 minutes of pressure after after this. And I'll show you a cartoon how that actually shows, and we have a couple of live cases. One Dr. Ramaya is going to show us and moderate as well. So you'll be able to see how it works. But one of the key hallmarks about this is with a standard Seldinger technique, you can see when you get access, you're going in at about a 45-degree angle through the skin. The actual length of the arteriotomy is so much shorter, probably a fourth to a fifth of the range of the arteriotomy that's created by the Axera device. So the thought is with this, it's almost like a check valve, or as I heard earlier today, a tissue door. So it's almost like you're able to create this sort of thing, but the surface area will enable you to basically have the arterial wall just hold itself back up with the pressure, so it self-seals. And here's just another more engineering picture that can, again, show you the angulation is so much less steep. It incorporates so much more surface area compared to our standard Seldinger technique. And the ingenious thing about this is as you pull it out, you can see the flap just basically closes up. And here's a movie I hope that will play for you here. Here you can see the actual sheath being removed at the termination of a case that was done with an Axera device. You can see at the very end, boom. It's almost like a fish mouth. Oops, let me go back there. Let's just play that one more time. So you have your 6 French sheath in, and you can see this arteriotomy that's very, very nice, and you can see it's self-sealing in that manner. So this is a nice angioscopy picture showing you all that there. So if you look at the recital trial, and this was a trial that was done with to look at the efficacy of this device, you can see with sheath pulls, the time to hemostasis was less than 5 minutes in the diagnostic arm and less than 10 minutes in the interventional arm. And within 15 to 20 minutes in the trial, the patient's head of the bed was elevated to 45 degrees. So the amount of patient satisfaction and comfort with this is great. Ambulation times was about 1 hour and 12 minutes and about 2 hours and 12 minutes in the anticoagulated interventional patient. The time to discharge for most folks was in the diagnostic arm 2.5 hours roughly. So you can see that the financial advantage for the hospital and for your own lab if you own it, I mean you're able to get folks in and out quickly. Of course with anticoagulation intervention in a coronary situation at this point most folks are still keeping them overnight, discharging home the following day. In my particular practice, I'm discharging most of my peripheral patients, I'd say 90% or so, usually about 4 or 5 hours later that afternoon. So this has allowed us to get our patients out of the hospital. So in the last 12 months, I've used it about 211 times, and my complication rate has been about 1% or less. I've had 2 hematomas that were easily manually compressed, but I have not had any major complications since I've started using this. And this is just in my last 12 months. Most of my cases have been, probably 60% have been using a 7 French sheath since I do a lot of atherectomy. And even with those, I've had no issues on the sheath pulls or anything like that. The ability to discharge the folks on the same day has been just really very rewarding, and not having to keep them overnight. I think if somebody actually sat down and looked at the cost and to demonstrate how fiscally responsible something like this would be, I think you'd probably be having a huge cost savings if someone was able to interpret all that data and put it together. So in conclusion, before you see a first case, I want to reiterate, I think the major concept behind this device is leave nothing behind, okay? The other big things are improve your throughput. It gives you the ability to get 4, 5, 6 cases done in your cath lab time on a particular day. The techs at our institution, they're now holding 3 to 4 minutes of pressure on these diagnostic cases. Even on a lot of my interventional cases, they're holding about 10 minutes of pressure. And across the board, you're seeing folks, even in our heart and vascular unit, which is our step-down telemetry area, I'll have patients and nurses, come at me and say, I don't remember what that Axe device was that you used, but, whatever it was, it took very little time for me to get back on my feet, and I didn't have a little knot like I did the last time when you did this procedure to me. So the comfort and the satisfaction amongst the patients, and certainly amongst the folks pulling the sheaths over on your step-down units, has really been very rewarding. Easy re-access, of course, great patient comfort, and the experience has been very good. So with that, I'm going to go on to a live case that we have here, and I invite Dr. Ramai up to show his case after this.
Hello and welcome to the Chicago Endovascular Conference. I'm Jaffer Golzar. I have with me today Dr. Girodi, who's our interventional fellow this year. Today we're going to be demonstrating the use of the Axera device for access of the left common femoral artery, but we're going to be doing it in a really cool way with these point of view glasses, so you'll be able to see exactly what I'm doing from my point of view. So I use Axera device because there's several advantages to it. I stopped using the standard access and closure devices several years ago when I had some complications with acute closure of the femoral artery. So we access the artery, and as you can see here, you have a latch at the end of the device itself, of the wire. Make a little nick. Pull the needle out, and we're going to attach the end of the wire to the Axera device. I use this technique where I loop, or where I scoop the device into the artery. You're going to see bleed back there. Deploy the heel actuator, pull back until you see decrease in flow, and then deploy the secondary needle. After deployment of the secondary needle, you're going to insert the 018 wire that comes with the device. And that secondary needle is what creates the super shallow angle arteriotomy. And the 018 device is now through that super shallow arteriotomy. Now we hold this and we pull this back, and that reverses everything. And then we very easily pull this back, and then you see the 018 wire. And we grab that and pull the rest of it out. Now you have an 018 wire through the secondary arteriotomy. Very easily place this sheath with the dilator adapter into the artery. Now that we're done with this, once we're done with the intervention, we're going to pull the sheath, about 5 minutes of hold, and we'll be done. 1 hour of bed rest for diagnostic, 2 hours of bed rest for intervention, with nothing left behind. That's how we use our stasis device. Thank you for joining us.
Very well done. So as you can tell in this video, he took about a minute to do it. He was talking his way through it, it's at the point now where when you start to do it regularly, it's probably taking about 30 seconds to put the device in, to make your arteriotomy, put your dilator attachment, and put the sheath in. And it's very rapidly done, and the patient comfort later on has been great. My hematoma rate at our institution was between 4 and 5%. We had lots of complications with vascular access, and since we've switched to this, our complication rate is about right at 1%. So we've been very pleased at our institution. Well, with that, I'm going to ask Dr. Ramaya to come up and do the other half of this. Thank you.
Thank you. I know Dr. Morissette is in the audience, so I have a question for him. So you've got this really nice device to create this shallow puncture track. Why can't I do it straightforward with the needle? Yeah, come on. I thought there would be a shortcut to it. So let's talk a little more about Axera, and I won't, some of these slides are repetitive, so I will basically showing you that there is a trial, the device has been tested, it is successful, and now it's ready for marketing. So the concept is this self-sealing arteriotomy, or a flap. And as you can see, the ones that we normally do is at a 45-degree angle, and this is almost at a much shallower angle, so you have a long track. And that's why I was asking, why can't you just do it with your needle pointing more shallow, and then poke it into the artery? So maybe that changes the direction of the tract, and therefore you don't get that nice, smooth, self-sealing arteriotomy. So that's the basic difference. And if you look at all of the data in terms of the patient study, there's a very low complication rate, and there's a very rapid time to hemostasis and ambulation, and the total complication rate major is 0.3, minor 1.6. So, and the device has undergone multiple iterations, and I'm pretty sure there will be more on the way to try to seal, larger sheets and other punctures. Right now, it's sort of approved for 5 and 6. We've done a fair amount of 7s, and obviously people like all of us will push it for larger sheets too. So it's much less painful. Hemostasis is much better. Patient comfort level is also is much greater than most of the other devices. But what attracts me mainly to this particular device is that same concept of leaving nothing behind. If it does fail, you just put manual pressure and probably seal even faster. So we've done about 200 cases of these, and I've done a couple of brachials and antegrade access with these too. Large majority of them have been for 5 and 6, and we've been using it for 7s very nicely too. The average hold time is 5. We've had 5 small hematomas that did not require any kind of intervention. We had 1 pseudoaneurysm that had to be injected. The hematomas were small, did not need any transfusions, and did not delay the patient discharge. So I didn't have those fancy glasses that Dr. Golzar had during his case. So I taped this case, and I'll show it to you once the case is done. We can then discuss. Is the video playing? Yeah. You find the vessel wall. See how steady my hand is compared to Dr. Golzar's? But I can't find the artery. We do it in slow motion most of the time. So one of the things that I had while the video plays and when I find the artery, maybe I had to call my fellow to do the puncture, but
once you get blood flow, fluoro,
yeah.
you
So
watch this wire,
wire
which
has
is a nice
undergone a lot of
floppy wire. This
iterations.
wire has undergone a lot of iterations over the last few years. This wire now allows for more tortuous calcified vessels to be treated.
This was a problem I had with the wire, which was stiffer, could not really make an angle with it, and so they've changed the wire, especially for small calcified tortuous vessels. And I always fluoro the wire, going up into the aorta. I think which is a good lesson to learn.
So once the wire is up there, the second step is to take this needle off and enlarge the
Dr.
arteriotomy
Golzar, if you
as would
notice, did
normally
not
do.
make the arteriotomy and the tunneling, because I had a feeling that I would have to use a larger sheet for this. Plus, this was a fairly obese lady, and the tract tunnel. So I tend to sometimes enlarge it, especially if I'm going to use anything else
It's then
or a larger
connected
sheet.
to this anchor here, which allows you to advance the Axera device.
So
It locks in
dilating the
pretty
tract
nicely.
can sometimes cause, more of a
And
problem,
now we
especially
advance
with
this
device.
wire
But
and
there's
the
no bleeding.
device together as a unit, keeping this anteriorly placed. And once it goes through, you'll see blood flow coming in through this little port at the back over here. Once you have this, you then plunge the anchor, pull the device up till that blood flow disappears. So now you have no further blood flow. So now you create a second arterial puncture by plunging this particular device. So once you plunge, you get blood flow back. So you've created a second arteriotomy puncture. And then you advance the 018 wire and watch it on the floor. And you'll see it goes through a different path altogether. So now you've created almost a dual puncture. You undo the anchor and basically remove the device with this particular wire here, which is the 018 wire. And once you've got the new one here, you connect that to the sheet that you use, and now you've gained access. Okay, hold that wire, please. Yeah, there you go. And then you advance the sheath in. So now basically you've got access. You can then use your regular wire if you want to. and flush this.
Any questions?
Vinky, was that a blade or was that a sword that you used for your arteriotomy? That was huge.
Come on. For the surgeons and the endovascular interventionists, let me make one nice statement. There is no person in this room who has the blade in one hand and the wire in the other hand who can do both equally well. And that is why I say, go ahead, Jaffer, do whatever you want. I can fix all your messes.
You know, a couple of points I will bring up. We started using the Axera a couple of years ago when we had some complications. I've been using it exclusively since then. And we've had some physicians also in our hospital that have converted to it. The advantages, is like, as the two esteemed faculty were saying, there's nothing left behind, first thing. Second thing, you can access and use this in bifurcations, which you can't do that with other devices, and you can use it in heavy calcification. So those are all very important exclusions for other devices that you can use this device. We have used it in 9 French sheets, and we've actually, our pediatrician has used it in 10 French sheets, with the 10 French sheet as well. And it's, you know, it's done very, very well. Obviously off-label, we're not promoting that, but it has worked in those situations.
There's also some, I think, new refinements that are going to be made to the device coming up here in probably September, October, which will make it even more exciting, where you won't even need the initial wiring, just do everything with the 018 wire. So it actually will be even quicker and easier. In addition, I think there's other iterations that Bruce would like to talk to some of you about. Any suggestions or thoughts you have? I've used it about 15 times in the brachial artery, again, off-label, with great success. Popliteal artery approach is another area where I have also used it. So, you know, other iterations of this device, perhaps smaller devices that Axera can put out for even radial artery access will be very exciting too.
One thing I will say is that it's actually interesting just for anyone that's had an opportunity to work with startup companies. They're completely different, and I'll tell you why. Is because, you know, I started using it initially with the J-wire that Dr. Ramaya was referring to, and we didn't like it at all. And we went back to the company and we're like, you know, we don't like this. Within months, we had a different iteration of a wire. So they take your advice, they take your suggestions, and they make the product better. So I think that's very, very important. I really like that about the company, and you really, in startup companies in general.
Yes. And I mean, I'm a heparin guy, so I don't know about the cardiologists and the interventionalists who use, you know, RioPro and Integral and things like that. But I think the question is for, you know, for the inventor. Come on. I think you should come to the mic. What are the limiting features of this particular device in terms of usage for larger sheets? What are the limitations for this, for expanding the indications?
Hello? We need to split the switch. Hello? It's not on. So I guess I'll just, yeah, oh, here we go. Yeah, like you mentioned, it's cleared for 5 and 6 French. There are a lot of doctors that have been using it for larger French sizes. With the particular angle that we go through the artery wall with, as you get to larger and larger French sizes, the advantage of the tissue overlap and the tissue door start to diminish. So there's a point of diminishing returns. And in order to accommodate larger sheets, you just have to have a longer overlap. So this one is designed for 5 and 6 French, and people are getting away with up to apparently 10, but that's the limitation right there.
10 French is not a bad goal to achieve, you know, with this particular technology. And a lot of the devices are getting much, much smaller too, so
Right.
that may be still very competitive, especially since you're not leaving anything behind, all the more reason. Yeah, you had a question?
Any situation where you know not to use it?
The question was, what is the situation where you know not to use it? So the one situation that I would not use it in is if you have an iliac occlusion, Because with this iteration, you have to be able to get your initial wire all the way up. So you have to be, and even if you have, let's say, a stent that you say you think you have severe disease, sometimes you can manipulate your wire, especially with the angled wire. Now, with the J wire, impossible to do. With the angled wire, you can kind of manipulate that up. But you have to get the wire up before you attach the device, and then once you push, then you have to push it all in as one unit. So that will, your wire will end up in the distal aorta, as you saw in both of those cases, in Dr. Ramaya's case. So that would be the situation where I really would not use it.
There is an iteration coming up where they're going to make it rapid exchange. So that also is going to make it much better too. You can have, I had one where because of the obesity of the patient and the angle of the puncture, that wire, as you're pushing the device in, the wire developed a bend in it, a kink in it. What do you do in that situation? And you can't advance it anymore because of that angle. So what would you do in that case?
Yeah, in that situation, that's why I used the scoop technique. We used to have a lot of problems with wire kinking right where the device attaches to the wire. Because it's going through the tissue, and the soft end is once it hits in that one segment, that's where you get that kink. When we use the scooping technique, that has completely gotten rid of that completely. The other issue that you will have with the device is sometimes you will have the dilator adapter will get kinked in very large patients. If that happens, then what you can do is you can use an 0-8 radial sheath. And that's very helpful in that situation. But those are the couple of issues that you can have with the device, but very easily fixable.
And I think some of those will be corrected with the new iteration that comes out in, I think, September, October.
Devices as a whole for interventional procedures right now? Not many. So otherwise, the rest of you do manual pressure on all your interventions? So if I give you two closure devices, AngioSeal and PerClose, how many use AngioSeal? Still the number one, yeah. And how many use PerClose? Suture-based, equal.
So guys,
Peter?
guys, what about patients who've had multiple prior procedures where you have kind of a scarring in the groin, where they've had prior closure devices? It seems to me that it might be some difficulty advancing that wire and the device as a unit through that kind of...
Well, in those cases, I use that long knife and that hemostat to create my track. And that's where when you have scarred groins like that, I think that creating that track, not going deep, but just creating that track in redo groins, post-operative groins, closure device groins, I think that's a good technique to at least create that initial track so that it then scoops nicely in.
I think with the new wire that they came out with, getting rid of the J and having a little bit more steerable wire with an angled tip, it's been better to be able to negotiate through some of these areas where there are previous sticks and there's little plaques and things like that. So it's been much more favorable.
It seems like that the second puncture is a little bit higher than the first puncture. If you have a high stick first puncture, then the second puncture will be even higher in this device. And also the device actually pushes the wire all the way in. Yeah, I'm just wondering if there has been a problem with losing the wire inside the artery.
I just jammed that wire into the device. It's never lost a wire yet, but it's a possibility if you don't really push it, or lock it nicely. It really locks really well. It's very unlikely you'll lose the wire. And in regards to a high puncture, high punctures, even with the initial stick, is a bad option any which way. So if your second puncture is still a little higher, that means your first puncture was still high. So it's like simple, puncture techniques of marking where the inguinal ligament is, where the femoral head is, and things like that. So that shouldn't be a problem. And if you had a high puncture, the second puncture is going to be high if you really go high. So again, you have to depend on your manual pressure, maybe for a longer time. Yeah. Question?
To me, there seems to be no advantage to use it on grafts, right? Stick a graft.
I think you're right. If it is a PTFE, like an aorta bifem or Dacron, I don't know whether you can use it, and I've not tried it. So Is there an indication to use it in grafts? You cannot, because you do not create that self-sealing arteriotomy.
Wouldn't this actually be your best device if you had too high of a stick? Because it's the other devices, the reason that they don't work is because you can't get the device, the suture, whether it be a minx, you can't get it to track through the inguinal ligament. So if you stick high and you go up there, you at least have the self-serving closure that will shut it. You might bleed a little bit, but you should stop technically after a period of time.
I totally
So this
agree
might
with
be your safest procedure for a high stick.
If you do get a high stick with this, it's actually, you're right, absolutely. Intuitively, at least you have some element of a seal rather than just plain manual pressure. If you have a high stick with a normal and put manual pressure, then you don't have anything to give you support in the external iliac because that's floating. There's no bone to create counter pressure from the top. Whereas with this, if it's a high stick, I totally agree with Frank. That's why he makes all that money.
And the other point about this is that even, that is a good point, but the other thing is that say you have a combative patient who's writhing all over the table and for some reason you want to go ahead and do a seal. You can go ahead and put an angio-seal in, even despite getting access with Axera. It doesn't limit your ability to use any of the other closure devices.
I'll comment as we close up and we start the next session. I have a challenge for Axera for your new iteration of the device, and it's based on this story. So a couple of years ago, one of the physicians was using this device, and he had a sheath in place, and you guys know this story. They had a sheath in place, and the sheath got caught by the screen, the shield, and the sheath got pulled out immediately, and the artery sealed on its own. And so the concept is if you could pull that sheath out so fast or do some other iteration to the device that it actually, overlapping arteriotomy seals up on its own, that you really don't need any pressure or only a minute or two of pressure, that would be amazing.
I think it was difficult for me to get used to was you put this at the front end of the procedure. So you have to literally tell your staff to open the device and keep it on the table, otherwise the fellow goes and punctures it with an 18-gauge cook needle, puts the sheath in, because most closure devices you do at the back end of the procedure. So you have to be intuitively trained to use it at the front end of the procedure.
Do you wait for your ACT to be below a certain value before you pull the sheath?
I use heparin, ACT comes back to normal, I then just pull it. I don't know about Integralin and RioPro. And
So at our institution, when it's below 175, we go and do a manual pull. With Angiomax, with whatever the ACT is, we stop the Angiomax. 90 minutes later, we do a sheath pull on the step-down unit. And about 2 hours of bed rest after that. With about 15 minutes, they can put the head of the bed up 45 degrees.
All right, thank you very much.